Well, thank you, Margot. Good morning. It is my distinct privilege to present this lecture in honor of Dr. William Hunter Harridge, especially here at our first inaugural combined meeting of the Central Surgical and the Midwest Surgical, and particularly here in Chicago. Dr. Harridge was born and raised here in Illinois. He, after serving his country with great valor, came back and did his MD at the University of Illinois College of Medicine, graduating in 1950. He studied general surgery under the tutelage of Dr. Cole and went into private practice in Evanston, Illinois. As Dr. Shoup mentioned, at a time when the Midwest Surgical was floundering, Dr. Harridge became the president of the Midwest Surgical, and under his guidance, he strengthened the foundation of this society, making it what it is today. Sadly, Dr. Harridge passed away of cancer in 1971. This lecture is also dedicated to Noni Lowry, and many of you know Noni and knew that she passed away just last year of metastatic triple-negative breast cancer. She was the founder of Lettuce Planet, etc., or LP, and managed several surgical societies, the Central and Midwest Surgical among them. So I thought it only fitting today to address this lecture talking about the promise and pitfalls of novel therapies in breast cancer. But what does any of this have to do with baseball? Aside from the fact that we're here in Chicago, the city of the World Series champions, and we'll be hearing from their owner tomorrow. Well, truth be told, anybody who knew Noni knew that she was the consummate Kansas City Royals fan. And as she was battling breast cancer, she would often be waving the banner of the Kansas City Royals, cheering them on as they had their own battles on the field. And what about Dr. Harridge? Well, there was only one man that Dr. Harridge respected and loved more than Dr. Cole, his mentor, and that was his father, William Harridge Sr. And William Harridge was the president of the American League of Baseball from 1931 to 1958. This was the time of all of the greats, Babe Ruth and Joe DiMaggio. And William Harridge served as the chairman of the American League Board of Directors until his death in 1971, just a few months after his son passed away. William Harridge Sr. was inducted into the Baseball Hall of Fame in 1972, a year later. And perhaps that's where this story starts, with the greats, all of the mentors, the people that we respect and admire, the people like the Babe Ruth and Joe DiMaggio. Well, if you ask any breast surgical oncologist who were the greats, there'll be a whole list. But among them are people like William Halstead and Joe Fisher, Umberto Veronese. But like baseball, breast cancer is made up more than just the big sluggers. You have to have good catchers and pitchers, fieldmen and first basemen. We've been very grateful in breast cancer to see a decline in mortality over the last several decades. And this has been due to contributions more from other disciplines than just surgery. This has been due to the advent of screening mammography, the discovery of genes like BRCA1 and 2, which gave us a new lens on prevention. And perhaps most importantly, it has been due to the plethora of drugs that we have discovered that have had a real impact in reducing breast cancer mortality. But as Babe Ruth said, the way a team plays as a whole determines its success. You may have the greatest bunch of individual stars in the world, but if they don't play together, the club won't be worth a dime. And that's how it is in breast cancer too. It's a multidisciplinary effort, and we have to know how to play together. Now, how surgeons and medical oncologists interact has been the source of long debate. For a long time, people argued whether surgery should go first, particularly in operable breast cancer. We, after all, are the ones who go in and extirpate the tumor. We get rid of the bulk of disease, leaving only microscopic cells for the medical oncologist to mop up. Now, the medical oncologists argued, no, people don't die of their local disease. They succumb from metastatic disease. And so perhaps it's important that they go first and treat cancer, leaving the surgeons to, quote, mop up. Well, thankfully, this went far beyond opinion and debate to finally be answered by one of the most pivotal trials, I think, in breast cancer management, the NSABP B18, which finally put this question to rest. Finally, we would know which side was right, and the answer, of course, was they both were. As you can see, the survival rate is equivalent whether patients are treated with primary surgery or neoadjuvant chemotherapy. But there are many advantages to neoadjuvant chemotherapy. It is perhaps the only way in which we can have an in vivo objective response of how people respond to chemotherapy. And that's important, because those patients who have a complete pathologic response, or what we call a PCR, do incredibly well. And you can see from these curves the correlation between pathologic complete response rates and survival. But not all breast cancers are the same. And so we know that certain subtypes of breast cancer will have better responses to chemotherapy than others. The more indolent cancers, those that are fed by estrogen and progesterone, those that have a genotype that we call luminal A or luminal B, tend to respond less well to chemotherapy, and the pathologic complete response rates are low. But we get nearly double or triple that response rate when we look at the more aggressive cancers, the cancers that are triple negative, like Noni had, those basal-like or Claudin-low genotypes that often are mediated by a phenotype that doesn't express either an estrogen, progesterone, or HER2 receptor. And those that are HER2 enriched also do very well. But these tend to be more aggressive. And so this can't tell the whole story. How is it that those patients who have a high pathologic complete response rate, when we look at survival, actually tend to do worse? Well, as it turns out, we can't really use these data in looking at differences between the subtypes. But this can give us a glimmer into how patients respond within subtypes. So if we have patients, for example, who are HER2 positive, those patients who respond to a HER2-targeted agent will survive longer, we anticipate, than those patients who don't. And the same would be true for triple-negative cancers. Now, the FDA was so impressed by that whole thought process, the idea that we could look at neoadjuvant outcomes from trials that we could do over a period of months rather than periods of years, and use pathologic complete response rate as a surrogate marker for survival. That when they saw that the pathologic complete response rate for HER2-targeted agents, particularly in patients who were hormone receptor negative, approached 80%, they were able to authorize an early expedited approval of those drugs based on neoadjuvant data. Because here's the promise: if those patients achieve a pathologic complete response rate when we have no other targeted therapy, and if pathologic complete response rate should mirror objective overall survival, we can have a real impact. This was going to be the home run that all of us were anticipating, and last month, as so many breast oncologists and surgeons gathered here in Chicago, we awaited the trial that was going to finally corroborate these data in terms of survival. The Affinity trial was presented at ASCO, and, well, it wasn't quite the home run that all of us expected. It was rather more like a bunt single. And while we found statistical significance, one would argue that this barely passes the laser pointer tests, and these curves seem almost superimposable. But how could that happen? We thought that pathologic complete response rate was a perfect surrogate for overall survival. But I guess it's unbelievable how much you don't know about the game you've been playing all your life. And so we go back and we look at subtypes and we look at whether or not pathologic complete response rate mirrors survival in all subtypes. Well, here are data that Judy Bowie just published, which finds that in the HER2 positive subtype, that subtype that was supposed to be that grand slam that we were hoping for, these curves are superimposable, and there is no statistically significant correlation between pathologic complete response rate and overall survival. But what about triple-negative breast cancer? That's the real bugaboo. That's where we have no targeted therapy and where we were really hoping that those neoadjuvant trials were going to help us. Well, the good news is that it seems that in triple-negative breast cancer, there is a very distinct correlation between pathologic complete response rate and overall survival. And so armed with these data, there became renewed interest in looking at new drugs that might be able to help us in a subtype which is so lethal. We don't have many options for triple-negative breast cancer. We often use standard chemotherapy, the anthracyclines, the taxanes. We know that platinum agents can be helpful, particularly in BRCA-positive patients, but wouldn't it be great if there was something more? Especially if there was something that could address metastatic disease, the kind that Noni Lowry passed away from. And so many people started to look at angiogenesis inhibitors, drugs like bevacizumab. And at least in the neoadjuvant setting, there were a couple of large studies that found pathologic complete response rates of 40 to 50%. And while these varied in whether or not they actually hit the threshold of statistical significance, this was perhaps yet another hope that we could find a drug that, for once, would be able to target triple-negative breast cancer. But when the large adjuvant studies were done, no improvement in survival was found. Now, why was this? Clearly wasn't the subtype. And perhaps it was statistics. Perhaps the adjuvant studies weren't powered to be large enough to find those statistical differences. Or perhaps the neoadjuvant studies weren't exactly perfect in their control groups. Now, we had two choices at this point. We could either become despondent and say, woe is me, yet another drug hits the dust, or we could keep swinging. And as with all cancers, and as with all disappointments, the importance is that we keep swinging. And so last year, immunotherapy came to the forefront. It became the buzzword that many of us used in melanoma and lung cancer. It was one of the most significant clinical cancer advances in ASCO, and Joe Biden placed it at the centerpiece of his cancer moonshot. And as we started to think about triple-negative breast cancer and the fact that so many of these cancers have a high rate of tumor-infiltrating lymphocytes, making us think that these cancers were perhaps immunogenic, and that if only we could remove that invisibility cloak that so many cancers invoke, that perhaps we could really make a difference in terms of triple-negative breast cancer. Last year, we started to get a little flicker, a little glimmer of hope with the Keynote 012 trial that was presented at ASCO and later published in the JCO, which found that in 111 generally heavily pretreated metastatic triple-negative breast cancer patients, immunotherapy resulted in an objective response rate of 18.5%. That's great. But who wants to use a therapy after everything else has failed? Wouldn't it be better if we actually had therapies that worked up front when people are initially diagnosed with triple-negative breast cancer? So our medical oncology colleagues and I at Yale started to look at an anti-PD-L1 antibody called MEDI4736 in a phase 1, phase 2 trial to see whether or not this, in combination with chemotherapy in the neoadjuvant setting, could make a difference. The data were presented here last month at ASCO and found no dose-limiting response, no dose-limiting toxicity. And 5 of the 7 patients, or 71%, had a pathologic complete response rate. Now that's great, but it's only 7 patients, and it's only a pathologic complete response rate. So the real question is, will this really translate into an improvement in survival, or will this be yet another disappointment? We don't know the answer, but we will continue to look. We are now in the process of creating a phase 3 trial to look at immunotherapy in triple-negative breast cancer. And perhaps that's the motto. As Babe Ruth said, we can never let the fear of striking out keep you from playing the game. But this is more than just the highs and lows, the pitfalls and the promise of breast cancer therapies. This is the story of what all of us do. For we all have those days, whether you're a surgeon or a scientist, whether you practice bariatrics or burns or breast cancer. There are those days when the experiment doesn't work, the trial shows negative results, the patient doesn't do quite as well as you would have hoped, or there are just so many administrative burdens that you think that this is just one more hurdle. Those days when it takes every ounce of effort you have to walk up to the plate and lift the bat over your shoulder. But it's in those days that you should remember the importance, the promise of persistence. It's because of that perseverance that we continue to play the game, and it's how we succeed. There were only 2 teams over the last 30 years that came back after being down 3-1 in the World Series to win the pennant. The first was the Chicago Cubs last year. This is in the home state of Dr. William Harridge. The other was the 1985 Kansas City Royals, the team of Noni Lowry. And both Dr. Harridge and Noni Lowry both fought significant adversity, both with their own disease processes, but also overcame incredible challenges to build organizations, to bring people together, to always keep going and never give up. They both made significant contributions to the Midwest Surgical Association, and for their contributions, we are incredibly grateful. And so it is their inspiration that keeps us keeping on. It has been my distinct privilege to present this lecture in honor of our late past president, Dr. William Hunter Harridge, and our good friend, Noni Lowry, and I am incredibly grateful to the Midwest Surgical for the opportunity afforded to me. Thank you.